so much. Good morning, everyone. Or I'm not sure if it's morning for you, but it's at least morning for me. So we're going to just try and go over a smattering of different pediatric disease processes that you might see in your career. And I've been doing pediatric emergency medicine for over 25 years. And so these are my 2 cents after a quarter century. Go ahead and switch. And I have no financial interests, no sponsorship. If we were in the same room, maybe there'd be a hat back there, so that way I could just take, you know, whatever spare change you might have to support that financial interest. Nonetheless, let's keep going. All right. Generally, I am known to speak fast, so you might kind of feel like this poor dog. But the goal of this is to try and go over a bunch of just general topics so that you have some exposure to the basics principles of pediatrics, and we will certainly have time for questioning and answering at the end of both these sessions. Okay, next. So there's a reason that we call it the practice of medicine. We need to practice. We need to get better at it, and I think it would be crazy to think that you are never going to screw up. That is an impossibility. We are carbon-based life forms. We are going to make mistakes, just inevitable. The only thing that's important from that, especially when we're dealing with medical situations, is that we learn from our mistakes, and whether that is going to be from the patients themselves or the families themselves, or just reviewing it in the literature and just thinking, how could I have done this better? That's the goal. Okay, so please don't ever berate yourself for making mistakes. That is the whole point of being a human being, and then just make sure that you are going to learn from it. Next. Okay, so this is a real crucial issue, especially it's become more so, I think, in the last couple of years, where things that you say can be absolutely misconstrued in how you meant to say them. Okay, so words have power. I have been told that since 5th grade, and my English teacher at that time said, you know, words have power, use them wisely. Because they might be able to interpret the words, it doesn't mean that they understand the words, right? So I think this is very classic for me as a male who has been married for over 20 years, because even though I might have heard what my wife said, I didn't necessarily listen or understand what my wife said. So please have an understanding before you walk into a medical situation that you want to try and present yourself, both be it physically and of course verbally, in the best way possible. And there's going to be sometimes a barrier between you and that patient, or you and that family, based on be it societal or ethnic or religious aspects. So you want to make sure that there is at least clear communication between you and the patient or family. Next. When it comes to working in the emergency department, empathy goes a long way, and I think that that's not necessarily just true of the emergency department. I think that's very crucial for the world of medicine in and of itself. So there are a bunch of typical phrases that you can add to. I'm so glad that you came in today. I'm so glad that you came in when you did. Families, and especially, you know, I'm going to focus on pediatrics. So parents are always concerned that they came too late, and literally too late for them might be like the child had fever for 12 seconds and I brought them to the ER. That's not necessarily the concern that you might have, and in fact you might be saying, well, why are you here for a complaint that's only been for 12 seconds? But I will tell you that as a person who knows nothing of auto mechanics, generally when I bring my car in because it is making some weird noises and it works perfectly, it's just like very frustrating for you to bring it to that specialist, and then all of a sudden everything seems fine. All right. In the emergency department, you have to understand that my job is very limited in the sense that I have 2 focuses of my world. One is to resuscitate acutely ill or traumatized patients, and 2 is to decide if they are safe to go home or they need to be admitted to the hospital. My job is not absolutely making a diagnosis. My job is just ensuring safety. Okay, so when I come back and I say to a family, hey, by the way, the ultrasound is negative, or the CAT scan is negative, or the blood work is negative, the question that still lulls in their mind is, well, then what's wrong with my kid? Well, everything came back negative. That's actually a good thing. So the big things that I'm worried about, the things get admitted to a hospital or go to an operating room, are not there at this moment. So it's important that you go home, we do supportive care, and then you have follow-up with your pediatrician, with your family practitioner, with your clinician, so that way we can monitor this as it potentially evolves, okay? And again, leading to that last statement of, you know, these things continue to evolve. Right this second, everything is negative, but in 12 or 24 hours or even 2 or 3 days, it might worsen. So you might be back tomorrow. Next. So in general, we are on their side, okay? I think that that has got to be the most important thing, that they have to perceive that we understand their concerns, we have heard their concerns, and we are on their side for both the evaluation of themselves or especially for their kids. Next. All right, so let's just take some basic cases. 3-year-old who's got 12-minute history of left ear pain, no prior ear infections. So in your own head, start thinking about what your differential is.
Also, you guys could use the chat and tell us what you're thinking. What's the differential?
Let's keep going. So this is great. So we got a few otitis media, but see, now you're anchoring, right? So the real question should have been, or the real answer should have been, I have no idea, I have to do an exam. So he's afebrile, he's normal respiratory rate, normal pulse rate, satting fine, he's in mild painful distress, but you look in the ear and you can't see it. You can't see anything other than that goo that you see right there. Okay, next slide. So earwax in and of itself could be a cause of discomfort. So there's a few different ways to approach the clogged ear. I will tell you, I am not a fan of ear curettes. You will cause more trauma than you will help with, okay? So less is more, and if there's anything that you will learn from me today is that my favorite phrase is the enemy of good is better. Okay, so if everything is good right now, leave it alone. Walk away. It is the hardship of people in medicine is that we always think we can do better. You will learn, and clearly you can see that I've learned because I have a very large forehead, very little hair, and what hair there is, it's all gray, is that after time you recognize, oh no, the kid's fine, leave them be, all right? So serum-lytic agents, and that could be just as simple as half water, half peroxide. It takes a little bit longer, it takes a little bit more effort on your part, but overall, you will not cause trauma by doing a little irrigation. As opposed to, again, anything that you shove into that ear in the attempt to remove it mechanically, you have the potential to injure the external auditory canal. You will cause blood later on, and families get a little bit upset when they came in for their child and then they leave and their child starts to bleed afterwards, right? Because when you irritate or tear the external auditory canal, blood will pool in that canal, and so it won't come out immediately, but about 30 to 60 minutes later, it might either reach a crescendo and build over that water tension and come out the ear, or the kid might finally do enough movement that blood starts coming out of their ear. And if you want to see a family coming back with Indy 500 kind of speed, that's the kind of case that will be. Next. So there's a lot of different things that you can utilize for serum-lytics. You know, it depends on what you have available. I am still a big fan of hydrogen peroxide. This is the most important thing that you have to do if you're going to irrigate an ear to clearing out the wax. One is it has to be room temperature. So you should be warm water, and it's going to be cooled down by the room temperature hydrogen peroxide. So when you put your finger in that mixture, it should not feel cold. It should not feel hot. It just should feel wet. Okay. Then you're going to draw a little bit of that and put it in their ear and stuff a 2x2 gauze or a cotton into that ear, and then walk away. See the next patient. So give it 10 or 15 minutes for it to start to work. Then you come back, take out that gauze, and then make sure that you again warm that solution up to normal temperature, to room temperature, because we don't want to do calorics on this patient. If a hot or a cold fluid goes into the ear, if anyone has not done that, I was the foolish person who offered my services for that example. You start developing nystagmus and you get horrific vertigo. So please don't do that to your patient. So all you're going to do is take that room temperature water. I generally do a 30 or preferably a 60 cc syringe, and then I use a butterfly. And basically what I'm doing is I'm cutting off the sharp point. So all I have is about 2 centimeters of a flexible wick, if you will, or a flexible hose at the end of my 60 cc syringe, and then I put that in the ear canal and I irrigate it. Sometimes you will need to use the auricle to kind of mobilize it so that you can move that external auditory canal into the right position. All right. Other things that you can use is, again, commercial products, but it just depends on what you have available. Next slide. Okay, we just talked about all of this. Want to give a little bit of time, and that at least that bottom right is a good picture for you to understand what I was talking about with the syringe, and then having just a little bit of a flexible tip that you can maneuver into the external auditory canal, you can mobilize it. But you see how they're pulling back on the ear, because this is an adolescent, almost an adult. So you want to pull back, and technically you want to pull up on the ear to get them to get that positioning correct. Next. Okay, so what if we have this instead? Next slide. So there's a ton of different things that you can deal with when we're dealing with foreign bodies, okay? For external auditory canal, for ear foreign bodies, if it's an insect or if it's something organic, you want to make sure that it is dead, because every time it moves, it hurts. I think the most glaring example I ever had of this was like a 35-year-old, super strong, like almost like he was written by Marvel. Like he was just rippling with muscles, and he was just taken to his knees and screaming and holding his ear because there was a bee that was stuck in his, and that it was stinging him. It's just that every time he moved, the bee would flutter its wings, and they would be close enough to his ear, to his tympanic membrane, that he would just scream. Okay, so it varies with what you're going to be taking out. But if it is a live, you need to kill it, and the best way to kill it was something viscous. So in the old days, we would use viscous lidocaine. But whatever you have available would be great. So just try and kill it first, and then you can remove it afterwards. Next. If it is graspable, you only have about a 2/3 success rate, okay? And then a 14% means that you've caused trauma to the external auditory canal, or the worst case scenario is that you have perforated the eardrum. Yes, that can happen, and yes, it hurts like crazy. So insect, let's keep going. Kill it first, good. Next. Lidocaine jelly, viscous lidocaine, isopropyl alcohol, mineral oil, whatever you have to basically asphyxiate it is what we're looking for, okay? Next. Okay, if it is organic, if it is vegetable matter, you want to try and avoid irrigating it if possible, because a lot of times it will make it more friable and harder for it to get pulled out. There is a little bit of increased risk of infection with organic matter, but not a ton. Oftentimes you won't know what the heck it is, and so you'll have to start with just basically either a alligator forceps or just any kind of forceps to just kind of probe it and decide, is it solid, is it friable, etc. Next. Okay, so foreign body from the east, I prefer irrigation. There are specialized extractors, it's called CATs. There is a non-formulary version of it now. There's a generic version of it. And basically what it is, it's basically a small Foley, okay? So the goal is that you put this behind the foreign body, blow up the balloon of the Foley, and then pull it out and remove the foreign body. So same thing can be done with a very small Foley catheter if you can navigate it into the space that is left. The whole dermabond on the end of the wooden dowel end of a cotton swab is theoretical at best, but it really doesn't work very well. And then last but not least, again, ear curette or alligator forceps. Next. All right, there is something also that's crucial when it comes to foreign bodies, is that the most competent and capable person is probably the person that should be doing it. Because unfortunately, the more people that try and remove a foreign body, the more likely that you will not be successful in removing the foreign body. Okay, please make your first attempt the best attempt. So unless this child is old enough to absolutely stay still, you want to immobilize them as best as possible. Next. Remember that in the space that you're going into, if you're using an alligator forceps, it comes in flat and then it has to open. So make sure that it is enough space for that alligator to come in to remove that foreign body. Next. There is some question about whether you should sedate. And again, if there's any concerns about this child not being as cooperative as possible, or at least you being able to wrangle them to make them as cooperative as possible, it is certainly something that you should consider. But the reality is that a foreign body in someone's ear, or even a foreign body in someone's nose, ultimately is not a tremendous risk. In the nose, the biggest issue you have is going to be something called aspiration, right? They could potentially suck it into their lungs. It is not common, though. Next. Again, so if it's not that bad, if we have the availability of a specialist, well, they can get it tomorrow. So it doesn't necessarily have to be tonight in the ER. Next. This is a procedure called mother's kiss, where in this child's case, the foreign body is in his right nostril. So she is occluding his left, no, other way around, excuse me. So his left nostril, and she is occluding, no, I'm right. I was correct. So she's occluding his left nostril and the foreign body's in the other nostril. And then she is breathing into his mouth to try and provide basically positive pressure so that it takes the foreign body from behind and pushes it out. Next. So that's an example in the top left of the extractors, where again, it just opens a small little balloon. Basically, you can see the balloon on the Foley, and then that's the theoretical possibility of the dermabond. Next. All right, so that's ear foreign bodies. What if there's got a 6-month-old who's now crying and you cannot figure out why the kid is crying? Next. Wake, normal breathing, so that's the evaluation triangle. Afebrile, breathing relatively normally, satting fine, child's just upset. Next. So you have to start having a differential for this, right? And before you start thinking about unicorns or zebras, you want to start thinking about what's the most common things that we see. Next. So corneal abrasion, it doesn't take much for an infant to basically put their hand and their establishing nail and just accidentally scrape their eye, or just it happens accidentally throughout the course of the day. So please make sure that you provide some Fluorescein to ensure that you're not dealing with a corneal abrasion, because if you've never had a corneal abrasion, let me tell you, they hurt like crazy. Next. So this is the trick of the trade. I was taught this way back in fellowship in the 90s, and I now have taught it to hundreds of residents and fellows along the way. So you need basically the strip of paper all the way over to the left-hand side is the Fluorescein. You need a medicine cup, and you need a couple of drops of saline, okay? The only thing that's missing from this is if you can provide proparacaine at the same time, just some kind of anesthetic, that would be the best combination possible. So you put the Fluorescein strip into the medicine cup, you put about a ½ milliliter at most of saline, and then 3 drops of proparacaine, and then what you do is you draw up basically liquid Fluorescein with proparacaine in it. So it's got everything that you need. If the child is really unable to sit still and you're concerned about getting this into their eye effectively, let them lay flat and put drops of it in the medial canthi like you're seeing there with just the saline. And then have them open their eye. The liquid will go automatically into the entire eye itself and you'll be done. Next. You have to think about hair tourniquets, and hair tourniquets can show up anywhere, on toes, on fingers, and even on male appendages, okay? When it comes to hair tourniquets, basically you can see the differential. If you're looking at the toe, you can see the color differential between it, the two. So you've got it kind of pink, very red and beefy, distal to the hair tourniquet, where it's more pink and relatively normal color proximal to the hair tourniquet. The goal is trying to unwrap this piece of hair in the most efficient manner. So if it's on a finger or on a toe, you can actually cut basically straight down so that you're not dealing with any kind of transection of any of the tendons. And basically what you're going to do is try and cut, and basically you're cutting until you start seeing uniformity of color of the digit, okay? On the bottom right, you can see that there is a suture removal hook. That's one of my favorite things that I utilize for this particular scenario. The reality is that you will not be able to see the hair, or I should say rarely will you be able to see the hair. So you have to know what you're dealing with and then approach it appropriately. You can use like Nair cream or hair removal cream, but that takes hours for it to work. And that is not something that's been shown to be as effective in the emergency department, just because it does require an increased length of stay. Next. When it comes to blocking a digit, this is actually one of my favorite things that I've learned in the past 5 years. It's called a translegal digital nerve. And basically what you're doing is you're going right at the first crease of the digit, and you're going straight down until you hit the tip of the metacarpal bone. Aspirate to make sure you're not in a vessel, and then inject. And what this is doing is a tendon sheath block. So that lidocaine is being drawn up into the tendon sheath, and it distributes it in the entire finger in a single injection, as opposed to providing a typical ring block, which is, depending on how you do it, either 2 or 4 injections. For a child, this is one and done. So it is actually quite beneficial in terms of minimizing the painful procedures before you get to taking care of whatever it is that you're working on, that distal digit. It does not work as well on toes, but it should work ultimately. It works great on fingers. So I'm a very big fan of this approach. Next. And again, this is just indicating anatomically about what we're doing. We're going through the tendon and going into the tendon sheath. So that's why we need to go all the way down to the bone, aspirate, and then as we inject, we are pulling up a little bit so that that lidocaine gets pulled into the tendon sheath and then distributed into the entire finger. Next. If we're dealing with sedation, intranasal is a good approach to it. And notice the word I said, it's a good approach. It's not great. Please be aware that the medication that you're choosing can absolutely affect how it's going to work. So if you're choosing a benzodiazepine and the child has some pervasive developmental delay, you might be unsheathing a young, small Hulk, because what it's doing is it is taking away any kind of inhibitions that the child might have already had. If you're using an opiate like fentanyl, it might work a little bit better for you. The most amount of medication you can provide is 1 milliliter per nostril. So you need to know what is the concentrations that you're dealing with so that they are appropriately dosed to that child's weight, okay? What's going on? Oh, there we go. Okay, sorry, I just lost my screen for a second. Okay, so go ahead, next one. So these are your doses for fentanyl or midazolam. And again, you just have to check on your concentration for the solution that you're utilizing before you provide it to the child. Next. If you're dealing with other aspects and you want to try and mitigate the pain, there are a lot of topical preparations that you can utilize. EMLA or ELAMAX can be used only in intact skin, okay? So I take that back. EMLA can be used should be used in intact skin. ELAMAX should be used in intact skin. ELAMAX might be able to be utilized in an open skin, but generally the preference and the FDA approval is for just intact skin. So that's for, in that top right picture, you can see that you're trying to prep a site for an IV placement. The difference between EMLA and ELA-Max is EMLA takes about 40 to 60 minutes. ELA-Max takes about 15 to 20 minutes for it to work and numb that topical skin. And you're just talking a few microns or millimeters of the skin surface that is going to be numb. In terms of open wounds, that's where you're talking about your lidocaine, epinephrine, and tetracaine, or if you're lucky enough to have the old standby of TAC, tetracaine, adrenaline, and cocaine. Cocaine was an excellent drug for vasoconstriction and also for pain relief, but that was for the medical grade aspects of it and not for personal or entertainment value. Next. All right, let's keep going. So we have a 7-month-old that presents with a red stool. Next. There, they presented with a red stool. So they are afebrile, a little bit tachypnic, a little tachycardic. Otherwise, they'll look fine and the exam is normal. So next. There are a lot of different food products that can lead to this. So please make sure that you ask about what did they eat in the last 24 to 48 hours. These are very classic things that can lead to red stools that will be guaiac negative. They will not be bloody. Okay, Omnicef is one of the biggest ones that is from the antibiotic family that can cause the stool red. Next. But this is the thing that we can't miss. We can't miss a button battery. So if there's any potential that they got into something around them, then we need an x-ray to look for this. Next. In terms of button batteries, the 2010 approach was that if it's in the esophagus, and we actually just recently had an esophageal form button battery that did cause erosion and perforation, and that was only a couple of weeks ago. So it happens in any ER in any location on the planet Earth. In 2010, they basically wanted them taken care of as quickly as possible. Next slide. In 2015, they basically are looking for younger kids, okay? And if there's an ingestion of a button battery that's bigger, they also will need an x-ray. So if the parent can bring in them and it's a tiny little button battery, that should pass through everything in the intestines and there should not be an issue. I will admit freely that it's very hard for me to not obtain an x-ray just to see where it is on that, in the location of the intestines. But the rulings from 2015 on was basically that if it's small, you don't have to worry about it as much. Next. So these are the 2015 guidelines. So there's no x-ray if there's an older child and if it's a small button battery, okay? And there's no co-ingestion. And you guys can read this, and there is a button battery hotline. It is run out of Washington, D.C. in the United States, and they are available 24/7, 365. Next. Okay, PALS, tricks of the trade. Next. So metronomes. So it is very hard to achieve the 15 to 2 that we're talking about for most kids, as opposed to the neonates where 3 to 1 has been shown to be better. But having a metronome as part and parcel of your CPR compressions and respirations has actually been shown to keep to the compressions and ratio and respiratory ratio better than without that music. Next. So next again. So again, compressions with adequate rate is going to be 72. Go back for a second, please. So with the metronome having it on, we drop dramatically if you can compare it to in terms of adequate rate versus too fast. Okay, so it makes a difference to keep it in time. Next, now. If there's an issue with laryngospasm, okay, and the classic drug that we talk about with this is going to be ketamine, there is a notch. And if all of you can follow along with basically put your finger behind the top of your ear around your auricle, okay? Slide it down until you get to basically right behind the earlobe and into the corner of the jaw. If you push there, you should feel pain that's radiating into your jaw. If you push in that spot and provide positive pressure ventilation, if you just use a bag valve mask, the laryngospasm should stop. So this is a great trick to avoid potentially getting them paralyzed so that they can move forward. Again, ketamine is the biggest one. Other drugs that can cause laryngospasm are not as common, but this was actually found about 40 years ago or 50 years ago now by a anesthesiologist. Okay, next. So again, this is just a quick idea of something else that you can provide to a patient other than just paralyzing them. Next. Okay, Selleck maneuver, and this might be old hat, and a lot of people might not even know what this is, but this was a concept that by putting pressure onto the trachea and pushing down, you would then obstruct the esophagus so that when you are bagging these patients for a prolonged period, you would avoid gastric distension of that air and avoid not only diminished tidal volume, but also potentially diminish the potential for vomiting. Okay, next. Basically, if you look at this slide, the top part is where you have the straightforward. So you have trachea over esophagus, or I guess cricoid is what the C is for. And then by putting pressure on it, all that happens to the esophagus is it moves to the side. So it is not obstructing things like we initially thought. There is no value whatsoever to this maneuver. Next. So we know that actually it can actually cause problems. It diminishes the effectiveness of your bag valve masking. It causes tracheal compression. So it's actually narrowing the most important conduit to the lungs in 80% of the patients. It impedes the placement and the use of an LMA. It can cause fracture of the cartilage itself. And all it does is displace the esophagus. It does not occlude it. Next. Okay, so this is, again, forgive me because this is for more of United States audiences, and I'm not quite sure what the pre-hospital situation is in your own individual shops. So let's just go past this. Okay, let's do this case. So patient comes in and they're fussy and they're hard to console, and this is their EKG. Anybody have any ideas what's going on? So generally in my mind, I think about, is it wide complex or narrow complex? And then I look at the rate. All right, I think you've had enough time. Go ahead and next slide. So SVT is the most common arrhythmia that we deal with in children, and children are wonderful in the sense that they're either too fast or too slow. I had a child, a teenager yesterday that was a pulse rate of 33. And so she got admitted for monitoring, looking for a potential eating disorder. So SVT is the most common arrhythmia that we're dealing with. It is generally a rate of over 200. So not 180 like you'll see in adults. It's generally 220, 200 at least. Males more common than females. Next. So the thing that you need to determine first is, are they stable or unstable? And the best way to determine that is level of consciousness and is there a blood pressure? Okay, so is the blood pressure adequate? So if they're stable, we can utilize vagal maneuvers to try and break the classic the cycle there with stimulating the vagal maneuver to try and kind of stimulate the vagal nerve, which will slow down the heart rate, which hopefully will give it enough time for it to go back into the normal rhythm of SA node, AV node, and then bundle of His. Okay, next. There's a wonderful study in Italy that looked at patients who are known to have SVT, and when the patient felt that they were going into an episode of SVT, they had them just stand upside down in a upside down handstand. And lo and behold, the vast majority actually stopped the SVT on their own. So they did not need emergent evaluation. They just then called their cardiologist or their physician who was following them for this, and they stayed home. It was actually relatively straightforward and easy. Next. This is actually pretty cool for SVT, and actually I will give credit to one of my fellows who just graduated last year for this. Adenosine, the problem with adenosine is getting into the heart as fast as possible because the half-life is seconds, milliseconds actually. So the problem is that you have to push this medication in and then follow it with a quick bolus to try and carry it to the heart as fast as possible. But this study actually showed that if you can put the adenosine into your flush, so that way you're just giving one big injection of the medication all at one time. Adenosine is actually stable in saline, so it's not going to degrade its capabilities, and it will actually provide a faster conduit by doing it in the flush in and of itself in a larger bolus, as opposed to the small amount and then followed by the flush. So I actually have used this multiple times, and I think it works wonderfully. So this is a good trick of the trade. Next. Bradycardia. I know you guys were talking earlier about epinephrine drips, and you were specifically talking about for anaphylaxis. I had a 17-year-old kid that was anaphylaxing in my ED. He had gotten 2 rounds of epi, and he did need to go on an epinephrine drip, and this was only a couple of years ago. So we do use epinephrine drips for anaphylaxis, and not necessarily for the CroFab issues that they're having. For this kid, he had eaten a nut, and he was not responding to the rounds of epi, so he wound up going upstairs to the ICU on an epi drip. Please remember that for bradycardia, epinephrine is now the first line. Atropine is only utilized if we think that there's a cholinergic cause for the bradycardia. So epinephrine is the PALS answer. Next. Okay, dehydration, next. So Andanzatron is something that you should be utilizing in your vomiting or nauseous patients. It is an enormous adjunct to the care of these patients, and more often than not can actually minimize the use of intravenous access or even subcutaneous hydration, whatever it is that you utilize. But one of the things that came up was, is there an issue with Andanzatron and causing a prolonged QT? Okay, so the reality was that there was no reports of arrhythmia with a single dose of oral medication. A lot of my colleagues for a while were trying to get EKGs if there was any history of syncope or prolonged QT or something like that. The reality, though, is that it does not cause a major issue cardiac with a single dose. In the patients that had a QT prolonging medication, the vast majority of those were receiving, 1/3 were receiving one chemotherapeutic dose, and 1/3 were preventing post-op vomiting. So they had been through the stress of operations. Next. Looking at the QT interval. And so the only thing that's important that you understand with this study is that it is done on healthy patients. So these are not acutely ill patients. So it's a different patient population, but at least you can infer some of the data. Next. So it's 100 patients. Most of them were 8 years of age, and their baseline QTC range from 388 to 501 milliseconds. So we've got outliers already in the control population. Next. And basically, go ahead, next. They had EKG performed. They gave Andanzatron, and it takes an hour for Andanzatron to start to having peak effect, but the effect aspects of it is 3 minutes. Next. The big change was 3, okay? There was 3 milliseconds. So the range was -43 to 45, so it does cross 0, but you have a fairly good p-value, but for the most part, you're talking a 3 millisecond change in their own QTC. So pretty minimal effect on the QTC itself. Again, this was a different group of children. It was not always the sick population, so take it as you will. Next. So it does not really affect the QTC of pediatric patients. It's not clinically significant, and there's been no other studies evaluating the effect on the acutely ill population. Again, so you have to just take this study with a little bit of a grain of salt. Next. In terms of utilizing Andanzatron for the child who's coming in with vomiting, next. It is absolutely a game changer. So for this study, they had 3 months to 5 years. It was double-blinded, randomized, so it was the best possible approach to this, looking at this clinical question. Next. And they received either oral Densitron, oral placebo, okay? And then they got standard approach to dehydration according to the WHO. Next. The failure of oral rehydration, which should be everyone, irrelevant of where they are on the planet Earth, that should be the #1 approach that we utilize to hydrating a child. Oral rehydration is the best way. but providing them a dose of Andanzatron absolutely led to less failure. So it is something that we should be thinking about and providing earlier on in their care. So it led to faster rehydration, less number of vomiting episodes, and better caregiver and actually patient satisfaction. Vomiting in and of itself is not a reason or not a contraindication to Andanzatron. Next. So a single dose of Andanzatron should be given prior to starting oral rehydration for children less than 5 years, and it has been shown safe up until basically starting at 3 months of age, which I'm sure a lot of you have never thought that you could give Andanzatron that young. Next. All right, we're, I think, towards the end here. So a 3-year-old presents not using her left arm. Dad, there's always a male involved when it comes to this, let's be honest, whether it be dad or their weird uncle. The dad lifted her up by her arm earlier that day, and ever since then, she started crying and will not use the arm. Her vital signs are fine. Next. So this is going to be classically a radial head subluxation or a nursemaid's elbow. It is very classic under school age years, so less than 5. If you can get the history of the arm was pulled or they fell and there was an not a traction injury, but they are hyperextended, that is a great way to understand that they might have a radial head subluxation, but they will hold the arm pronated, flexed. When you're examining them, there is no tenderness to the elbow itself, and there's most importantly no edema, okay? If there is any supracondylar fracture or even radial head fracture, there is going to be swelling and pain in that area. If there isn't any of that, and you have the thought process that this is a radial head subluxation, there is literature to support that you should just go ahead and reduce it. So I know I've been talking consistently now for almost 40 minutes. I just want to hear from you guys. Okay, so this is the video for radial head subluxation. So this is the annular ligament, and that's exactly what happens. The annular ligament gets trapped on the top of the proximal radial head, okay? And that's why they won't move their elbow, because it is sublux. It's not dislocated, but it is not in the position it wants to be. So the maneuver we do will then put that annular ligament back down above the head, above the radial head, and back in position. Next. So classically, again, it's a traction injury or an extension injury. And again, that radius is now moved out of place and they are uncomfortable. So that is why they hold that arm, that pronated, flexed position, tucked in. And does anybody know where they will complain of pain? Will the child complain of pain in the elbow, in the shoulder, or in the wrist?
You guys can respond in the chat.
There you go. So let's keep going, and then that'll be the bonus question that they can answer. Wrist, correct. So it hurts in the wrist. So it travels down and radiates to the wrist. So they'll point to their wrist, but if you examine them, there's no pain there. So if you continue to examine them, and there's again no edema, no tenderness at the elbow, well, we have a winner. We have a patient who probably has a radial head subluxation. Next. So Al Sacchetti, who's a friend of mine, looked at the study, said, do you always need that classic story? Or is a patient who shows up in holding their arm in the classic position and complaining of upper extremity pain, is that good enough? And basically, the answer is yes, it is good enough. So you should consider a radial head subluxation in a pediatric patient, preferably less than 6 or 5, that's complaining of an upper extremity pain, and they're holding their arm in that classic nursemaid's position. Next. So Charles Macias in Texas looked at this and he said, how often are we getting x-rays? And is there a risk that we're missing a radial head fracture in these patients? Next. So basically what happened is that we are ordering x-rays on these kids when we think it's a radial head subluxation, but we don't get the pop that we are all known to enjoy and prove that the child is now back to baseline, that joint is back in position. We get a x-ray when we're concerned that for some reason it's not going back into place. The actual risk of having a radial head fracture or even a proximal radial neck fracture is extremely rare. The relative risk is like 1.2, so it's basically the same. The relative risk for a child with a non-classic that the arm got pulled is, again, not clinically significant and not statistically significant. The most important thing that I got out of this study was that if there's a bad enough nursemaid's elbow that you couldn't reduce, it can actually show up with a posterior fat pad, which we isolate and think about only for those kids who have a supracondylar fracture. But in a bad enough nursemaid's elbow, you can get a fat pad sign, and it is not necessarily pathologic in that one case. Next. So there's a couple of ways that you can reduce a nursemaid's elbow. When I was growing up in the medical world, we did supinate and flex, and ultimately about a decade or 15 years ago, they started talking about hyperpronation. And the Cochrane Review looked at this and said, well, hyperpronation seems to be more successful, and ultimately it seems to be less painful to the child. Next. So again, multiple randomized trials, meta-analyses looking at this, and generally hyperpronation is more effective than supination and flexion. Okay, you needed to treat 4 patients with hyperpronation to be successful, as opposed to supination and flexion. And in general, the risk of this radial head fracture was extremely low. Now you can go to the next one, that's fine. So this is what we're talking about. We're worried about missing either a fracture or a dislocation of the radial head. It just doesn't happen in the same age group that we are talking about when we're dealing with a nursemaid's elbow. This is going to be far more common in an older child, in a school-age child, so above 6. The other thing, I don't know if you guys can see this though, on the left-hand side, on the left x-ray, can you see the physis, and can you see how it's angled a little bit up? That actually is also a physeal injury as well as located, okay? Next. So radial head fractures, again, are the older kid, the school-age kids. It can be a Salter-Harris 1 or 2. Metaphyseal or 2 is the most common. For the most part, it is about only 10% of elbow fractures, and there's going to be tenderness and there's going to be swelling. So those are the 2 big things that you cannot miss on your examination of the musculoskeletal exam in these kids. Next. All right, so this is a good video. So you can see that she is holding stuff right now with her right arm, and she's moving that, but she does not want to use her left.
Not using that left.
And she's fine as long as she doesn't move that left arm. Okay. Not upset yet.
So do the hyperpronation.
Nervous. Okay. We cared so much that we made her cry. Okay. Next slide. So if you just focus in on what we're looking at, we got fingers on the radial head and just a tiny twist, but it has to be, you have to do it. You can't be wussy about this. You have to get it done. This is literally 3 minutes later.
That's good. That is perfect. We got the dog and the
juice sign, and we have a very happy child. Okay, so everything is back to normal. Next. So that's it, guys. That's 25 years in 48 minutes. Do you want to take a break? Do you want to ask some questions? I will defer to Shelley for the next part.
All right, guys. So we do have a break scheduled between 8:55 and 9. So we have a couple minutes. If you want to send in questions, you can send them via the chat right now, and we're happy to answer them. And then we'll take a 5-minute break afterwards. And great talk. I love that video. She's so cute.
She is cute. You know what's funny about that is that I was giving a lecture at EM Essentials and by the way, in San Francisco. And I asked that mom, do you mind if I take a video of this because I'm lecturing on this? It was a 20-minute lecture on elbows. And said, oh, I'm fine with that. My sister is an ER doctor. So I go across the country, I give the lecture, I show that video, and afterwards, her sister, the child's aunt, is in the audience and comes up to me and says, that was my niece. And it was just like,
small world.
Really crazy small world. Yes.
Small world. Okay, so we got a couple of questions coming in. First one was, how can the earwax production be reduced?
You can't, and that should not be your goal. You cannot stop production of earwax, and more importantly, you do not want to stop the production of earwax. Okay, so for those people who are overproducing earwax and all that other stuff, that the only thing that they should do is that every couple of weeks or months, depends on how much they produce, that they want to have that ear cleaned out, and they can do it easily at home with Debrox or some other over-the-counter preparation. The only time it becomes important for you as a clinician is when they're coming in for ear pain and you can't differentiate, is it a cerumen impaction versus an otitis media, and you need to remove it. And that's the only way to deal with it.
All right. And our next one, can you explain again what the doctor did with the left arm of the child?
Oh, sure. So, I don't know, can you see my left arm? Okay. So all I'm doing is so my two fingers are up here at my elbow. All right. So I've got basically one on the condyles, if you will, or the medial and lateral condyles. All right. But basically by having my thumb on the lateral condyle, I am as close to the radial head as possible. And all I'm going to do is just hyperpronate that arm. But I'm not going to be wussy about it. I'm going to hyperpronate the arm. It is just a quick and easy maneuver. And there's tons of videos that you can watch just to understand a little bit better than me on the intranet here. But it is straightforward and easy. It is not complex, but it's no longer the supinate and flex. It is just hyperpronate.
And it's the most satisfying pop, if I must say that.
It is the only time in emergency medicine that we are looked upon like we are magic. Okay, it is absolutely true.
All right, our next question, the red stool. What diagnostic tools are used to determine pathology outside of food?
All right, so again, so the goal is this blood or is this not blood, right? Because that's what the parent's concerned about. They are concerned that the child is having red blood stool as opposed to thinking it's something else food related, beets, fire Cheetos, what have you. So if it is guaiac positive, you're testing it and there's blood in it, that's a completely different conversation than what we were having. I was just trying to give you ideas of what other things can cause red stool that is not blood. If it is bloody, it can depend on the child's age as to what is causing it. For a neonate or 1 to 2 months, she's just a fissure. But again, is it blood streaked on the stool or is it blood within the stool itself, right? If it is external to the stool, then it is probably something more in the rectal area than actually in the intestines area. I have had full-on gross bright red blood and a piece of tissue. And so auto-amputation of polyps, of juvenile polyps, is actually extremely common in younger children, and probably, again, less than school-age kids. But it just depends on the age of the child and in terms of blood or not blood, in terms of how far you're going to go next.
All right, and I think this is our last question before the break. Okay, nasal intubations, have you ever done those? I don't know if we could actually answer that question. I've never done a nasal intubation.
So I'm old, so yes, I've done nasal intubation.
Yes, you have. Okay, sorry.
It's okay, it's fine. There is no role for nasal intubations any longer in this day and age. I really can't see a reason, unless there is horrific oral trauma. But honestly, if there's terrific oral trauma, I still need to be able to visualize the endotracheal tube and grab it with my McGills so I can bring it down into the airway. So at this point, I'm just going to crike them or get surgery and we're going to just trach them. So the answer to that is that no, there's no goal or reason to do a nasal intubation anymore.
All right, then they're saying shoulder subluxation reduction, and also one person asked, is the radial head subluxation, if you have it once, does it make them predisposed to it in the future?
Thank you, that's a great question. So yes, if you've had it once, the annular ligament can get stretched, and so it can be more predisposed to it, but typically by the time they get to 6 years of age, the annular ligaments become so thick that it stays in place. So yes, a nursemaid's elbow can become a little bit more of a common issue. There are some people who actually teach families how to reduce the nursemaid's elbow. I can't tell you that I'm one of those clinicians, but it is certainly possible for it to become more chronic. And just like any a ligament, it could stretch and become uncomfortable. Just like an ankle sprain, you can have more and more injuries the more sprained it gets. In terms of shoulder subluxation, I'm not quite sure I understand the question.
I don't really know. It's a they're asking for method of reduction for a shoulder subluxation, or maybe they meant
Shoulder subluxation. Basically, it's just they're either holding it in the wrong position. Basically, just put them through a range of motion. That's it, and it should go into position.
Awesome. So now, guys, we